Welcome to the importance of biomarker testing. During this seminar, all participants will be in a listen-only mode. There will be a question and answer session at the end of the presentation using questions submitted through the Q&A feature. Please remember that information provided in this web seminar is not intended as a substitute for your physician's guidance and care. My name is Sarah Rothschild, and I am the Executive Director of the LifeRaft Group. We would like to thank Blueprint Medicines, Genentech, Decipher, and Novartis for their educational grants for today's webinar as part of our webinar series. And now I'd like to introduce our presenter for today. Dr. Michael Wagner is an assistant professor of medicine at the University of Washington and an assistant professor in the clinical research division at the Fred Hutchinson Cancer Research Center. He's the director of sarcoma clinical research. After graduating from Harvard University with a medical degree, Dr. Wagner completed his residency at Mount Sinai Hospital in New York and medical oncology fellowship at the University of Texas MD Anderson Cancer Center. Dr. Wagner has received numerous awards, including the Concord Cancer Foundation of ASCO Young Investigator Award and Quad W Foundation AACR Fellowship for Clinical Translational Research for his research on sarcoma. Dr. Wagner has been in his current position in Seattle since 2017. And with that, I'd like to pass the baton over to Dr. Wagner to begin his presentation.
All right, thank you very much, Sarah. I'm excited to be here, and thank you for the invitation and for the introduction. Just give me 1 second to share my slides. Okay, so you should be able to see my slides. So as you all know, the topic of this talk is the importance of biomarker testing for gastrointestinal stromal tumor. So I'll focus a bit on biomarker testing, but at least in the beginning of my talk in a much more general sense, and then I'll get a little bit more in-depth about mutation testing specifically. First, these are my disclosures. One relevant one is I do some consulting for Decipher, which of course has a drug approved for treatment of gastrointestinal stromal tumor. But first, as most of you know, so gastrointestinal stromal tumor is a type of sarcoma, where sarcomas are cancers of connective tissue in a very general sense, and GIST is a very specific type that we treat very differently because of the biology of the disease. It's rare, as are most sarcomas, where there are about 3,000 to 5,000 cases of GIST per year in the US. And it's a cancer that arises from a cell that's in the gastrointestinal tract called the interstitial cell of Cajal. And these are specialized nerve cells that essentially just help move food along the gastrointestinal tract. So they're in the esophagus, stomach, intestines, and sort of we don't think about it, but these cells help food go from our mouth all the way out. This is just another way to see that. So, of course, the gastrointestinal tract includes many organs, the esophagus, stomach, intestines, rectum, and anus. And these cells line that whole tract. So just tumors can come up really anywhere in the gastrointestinal tract. And they arise from these cells that are within the wall of the muscle. For treatment, if GIST is localized, we would want to do surgery, and that's pretty much a standard recommendation as long as it's feasible. But for many cases, we'll use medicines, especially with a class of drug called tyrosine kinase inhibitors. And these have now been around for a very long time. So the first one, imatinib, was approved, I don't even know, probably about 20 years ago. And we'll use these in a number of different situations. So for some patients, we'll have to actually give them before a surgery to try and help facilitate a surgery, where the goal is really to actually shrink the tumor to either make a surgery possible or to minimize the impact of a surgery that might come out from, say, removing an entire stomach versus removing just a part of someone's stomach to remove the tumor. But then also, even after surgery is done, for patients whose tumors are deemed to be high risk for coming back, we'll use imatinib generally to try and actually prevent a recurrence and ultimately make people live longer. But then also, if a tumor has spread, then we'll use tyrosine kinase inhibitors as really the mainstay of treatment, because we have to treat essentially as much of the body in multiple different locations with different tumors as possible. So historically, before tyrosine kinase inhibitors were introduced, patients would have surgery. And if you take all comers with GIST who have surgery alone, about 50% will eventually have a recurrence. So that means actually almost 50% of people were cured with surgery alone. But there was a huge need for those other half of the people to try and prevent recurrences and hopefully make it so that they never have to deal with GIST again. And then when imatinib was introduced, those numbers really dramatically changed, where the overall survival of patients with GIST, once imatinib was introduced, improved from about 50% at 5 years to close to 90%, which of course is a very dramatic difference and improvement. And from this study, so this chart that you see, that was one of the original studies of imatinib in GIST. So once this was demonstrated, imatinib has become now routine care for patients, especially with high-risk GIST or metastatic GIST. Of course, not everybody needs imatinib, so we now have developed a number of different risk calculators to try and actually quantify what is the likelihood of someone's GIST coming back after it's been surgically removed. And there are a number of different calculators, but they generally all consider the same features of a tumor. And in a sense, these risk calculators are actually a biomarker for predicting recurrence of GIST. And that's because it's taking factors intrinsic to the tumor and then actually using that information to guide first risk and prognostication. So what's the likelihood of this tumor coming back? And then it also actually helps guide therapy, and that patients who are deemed high risk will get started on imatinib, whereas those who are low risk will not. And the key features that go into this calculation are primarily three things. So one is the size of the tumor, where larger tumors are more likely to come back, which intuitively makes sense. The mitotic index, which is essentially, so literally when the pathologists look at the tumors after it's been removed or after a biopsy has been done, they look at it under the microscope and then count the number of mitoses, where a mitosis is a cell that is dividing or growing. And they count them and assign a number based on how many of those cell divisions that they see. And then we dichotomize it into either low or high, with 5 generally being the cutoff. And that's actually one of the biggest drivers of this risk score, where if someone has a high mitotic index versus a low mitotic index, with all other features being the same, the person with the high mitotic index is actually much more likely to have a recurrence. And then the other factor that generally contributes is, where was the GIST originally? So as I mentioned before, these can come up anywhere in the gastrointestinal tract. Ones that arise in the stomach generally are less aggressive than ones that arise in the small intestine. Of course, that's not always the case, but as a general rule, we consider small intestine tumors higher risk. And really, when we take those three characteristics, the size, the mitotic index, and the original site of the tumor, we can at least roughly assign what is the likelihood of this tumor coming back. And it's all, a bit of statistics and chance, but it helps us decide who actually needs to be on treatment after having a surgery. So that's one type of biomarker, but there are many types of biomarkers. And biomarkers can be many different things, where one of the key things that we look for in a biomarker is that it's giving us insight into a biologic process. So for GIST, we're interested specifically in the tumor process and trying to understand how is this tumor going to behave, or also how is it going to respond to therapy if we need to start therapy. And many different things can be biomarkers. So we even talked about just tumor size as being a biomarker, which is true, but there's many other ways that we can describe a tumor or other factors that we can look at to help our decision making. Some things that are relevant for GIST. So of course we look at the proteins that are in the cancer cells, and that's especially important for even just establishing the diagnosis. We'd look at changes in the DNA, which we'll talk a lot more about in a few minutes. And then other tumor characteristics too, like the mitotic index, for example. These are useful because they help us actually identify this tumor as a GIST versus some other type of sarcoma or even something that's completely benign. And they also help us guide treatment and determining what is even someone's prognosis as a separate use of these. There are many different types of biomarkers and also different uses of biomarkers. And a number of groups, so I actually took this information from the FDA's website as part of their guidance for drug companies and testing companies to try and actually sort of well define what is a biomarker and what are the different uses of it. And they actually use this information in sort of guiding how companies submit for drug approvals or testing device approvals. And if you're using a biomarker as a basis for whatever approval you're seeking, it has to fit into one of these categories, where there are some biomarkers that are looking to see what is the risk of developing a disease or developing whatever the company or the researcher is looking at. There are diagnostic biomarkers, and we'll talk a bit more about that for GIST, where some markers are used really just to even establish the diagnosis. Some can be used for monitoring. An example of that is, so for other tumor types, like breast cancer, colon cancer, prostate cancer, there are actually blood tests that we can use and follow over time, which helps us understand, is a patient responding to treatment or not? We currently don't have a really approved one for GIST, but we'll talk a little bit at the very end of my talk about how that might actually be changing in hopefully the near future. There are prognostic biomarkers, where these are markers that really don't impact treatment per se, and we wouldn't take a prognostic biomarker and say you need to be on this specific drug, but they can impact the aggressiveness of the disease, and it helps us just counsel patients in terms of what's the likelihood of this coming back, what's the likelihood of survival over any given period of time. Versus a predictive biomarker, which is specifically used to actually try and predict who is going to respond to a drug. And of course, those are relevant for GIST. And then finally, or a couple more. So pharmacodynamic biomarkers, which are specifically to look and see, is the drug that we're giving doing what we think it's going to do? So an example of that would be, if we were to treat someone with GIST with imatinib, are we seeing changes that we would expect to see by blocking that KIT protein? And we'll talk more about that, what KIT is, in a second. And then finally, safety biomarkers will show what's the likelihood of someone developing a toxicity. And that's a little bit less relevant for GIST, but I guess one example would be, it's not quite a biomarker, but if we were to know that someone metabolized a drug like imatinib differently, then we would potentially have to dose it in a different way, where that's not something that we typically would consider for GIST, but that is relevant for other drugs. So just a few examples. I already mentioned some of these, but ones that are especially relevant for GIST and are used in almost daily use in the management of gastrointestinal stromal tumor, our first diagnostic biomarkers, where, how do the pathologists even identify that a tumor is a GIST? So one of the main things they use is looking to see, is there KIT protein expression in the tumor samples that have been taken, whether it's a biopsy or a surgery specimen. We'll use predictive biomarkers to actually help guide the drug, where certain mutations are more likely to respond to some drugs versus others. And that's important. And we really recommend that anyone, I'm going to say this a bunch of times today, but we recommend that anyone who's getting started on treatment for GIST know what mutation they have that's driving their tumor. And then finally, prognostic biomarkers. So I mentioned the mitotic index before, where someone with a very high mitotic index is more likely to have aggressive disease. And that would be considered a prognostic biomarker that we would use in our decision making. So just some definitions before I go on in a little bit more detail. So first, immunohistochemistry, where I'll say IHC or immunohistochemistry as if, I say it all the time, which is true, but it's not a term that rolls off your tongue. So what that specifically is it's a way to look for proteins in a clinical sample. And I have some pictures, I think, on the next slide as examples. But immunohistochemistry is specifically looking for proteins. It's not looking for DNA changes. In order to look for DNA changes, you have to have mutation testing, where there are a number of different ways to do that. But the key thing with mutation testing is that it's looking for changes in the DNA that ultimately will change the structure downstream from the DNA in a protein that will then alter the protein's function and lead to sort of abnormal behavior, which is how GIST tumors grow. So how do you actually do mutation testing? So you have to sequence the DNA. And a few decades ago, there were only a few ways to sequence the DNA, and it was very time intensive, very expensive, and you had to actually know what you were looking for. So a few decades ago, really the only thing that existed was targeted or hotspot sequencing, where we would use certain techniques to specifically look for mutations in areas that we knew were highly mutated. And if they were there, then you knew. But if they weren't, then that's really all that you would know, that those specific spots that you looked at did not have mutations. It didn't give you any information anywhere else in the DNA or in any other genes that weren't looked at. And then over the past, I don't know, probably 15 or so years, something called next generation sequencing has been developed, or NGS for short, where that has really revolutionized the way that scientists and clinicians can sequence DNA. Just as an example, so for the Human Genome Project, I don't know what it cost to sequence the first human genome. That was probably exactly 20 years ago when it was first published, but that cost billions of dollars to get that done. Now, using NGS, we can sequence an entire human genome in a relatively short period of time, and actually for relatively cheap. So something on the order of a few $1,000s we can do today versus it cost literally billions and took many years, really not too long ago. And taking advantage of NGS, we now have much more power to identify mutations that could be potentially driving GIST, where even just 10 or 20 years ago, we just simply didn't know that those mutations existed. And finally, one last term that you'll hear a few times in this talk is an exon. So what is an exon? An exon is essentially the building block of a gene, where any part of a gene that eventually will go into a protein is considered an exon. And there are many different exons in one specific gene, and we number them just literally 1, 2, 3, 4, 5, as many as there are. And that's when we talk about exon 9 mutations, exon 11 mutations, exon 13 mutations, what we're talking about is specifically in what segment of that gene is that mutation seen. So first, I'll talk a little bit more about IHC, where, as I mentioned, it's a technique used by pathologists, which they use routinely every day when they're looking at surgery specimens or biopsy specimens, and they use this to identify different proteins that might be in a tumor. So different tumors have certain proteins that are characteristic within them, and that's how the pathologists can name a gastrointestinal stromal tumor versus a leiomyosarcoma, for example. And what they do is they take that surgery specimen and they stain it with special stains. And some of them are more targeted, and they can actually look specifically for with actually very good accuracy, looking for one individual protein. And this picture is just an example of that, where on the left, that's a picture of, I forget which organ, but I think it's the stomach. And what they're staining for here is KIT. So KIT, which is the protein that is one of the main drivers of gastrointestinal stromal tumors. And on the left is actually a normal stomach lining, where those interstitial cells of Cajal will stain positive for KIT. But it should be somewhat sporadic, and it should be just a few dots here and there, like you're seeing on the left. On the right, that's actually a gastrointestinal stromal tumor. And because these are cancers of those cells that are staining brown on the left, the tumors are essentially uniformly positive for the most part, and it should actually be pretty strong staining. And this is actually how the pathologists will generally differentiate a GIST from many other types of sarcomas or even other cancers. And just to sort of point out, again, that positive staining is the brown areas that you can see. And there are a number of different markers that they'll look at. So KIT, of course, is the most common one, where essentially all GISTs are generally expected to have KIT positivity. KIT is also called CD117. But they can have expression of these other proteins too. So I'm not going to get too much into those, but they don't necessarily have to have those proteins in the tumor. Another protein that you'll see more commonly also, this was just developed a little bit later from the paper that I took this table from, is a protein called DOG1. And that's actually a calcium channel that is very commonly seen in GIST tumors. And that also is used to help establish the diagnosis, where just like with that brown staining for KIT that I just showed you, there's a similar type of staining that we would expect to see if we look at the DOG1 expression in those tumors specifically. And all of this is done by pathologists. So these are not tests that I personally do, but we order them and we ask and work with the pathologists to try and get more answers and establish the diagnosis. And then also same with the mutation testing, where to have an expert pathologist review your tissue is very important, because if you look at all of these pictures on the left, except for that bottom left one, which is the normal stomach lining, all of those are actually GIST tumors. And when I look at these, I don't know the difference. Where I really need an expert pathologist to tell me what exactly these patterns are and what are we looking at. But even though these tumors all look different, even though I don't have the picture, if you stain them all for KIT with that brown stain, they'll all be very diffusely positive. And that's one of the ways we know that these are all gastrointestinal stromal tumors. And that's essentially a diagnostic biomarker that is just used to even establish the diagnosis. So then what about mutation testing? So all GIST tumors will have IHC tested essentially to establish the diagnosis. Otherwise, we wouldn't be calling them GIST tumors. However, mutation testing is a different type of testing. So if you remember, that's looking at changes in the DNA specifically. And that testing has to be done separately and ordered separately from IHC. And that's a very important point. So that's why I bolded it and put it all caps and underlined. It's because not everyone really understands that. Even oncologists don't always understand this concept, where sometimes, and I've seen this even sometimes from people who are referred, where they'll be told they have a KIT mutated GIST, but really what they have is a KIT positive GIST by IHC, which doesn't give us any information whatsoever on the mutation. So that's a completely separate test that has to be intentionally ordered. And I took this information just from the LifeRaf Group website, where, of course, they have a wonderful database of patients with GIST with a lot of information that's useful in it. And when patients input their data into that database, only about half of them, many of you, might even be in this database, only about half of people who put their tumor characteristics or put their tumor information into the LifeRaf Group registry know their tumor mutation. That doesn't necessarily mean that it wasn't checked, but for many of them, it probably does. And I think the LifeRaf Group, in putting this seminar forward, and then also just in their other activities, is really raising the awareness of the importance of knowing your mutation. And I'll talk about why it's important in a minute, but it really can change treatment recommendations, specifically because certain mutations are expected to be sensitive to different drugs or be resistant to certain drugs. And if we know that a drug is not likely to work, then of course we wouldn't want to use that. That's what I just said. So we're looking for all of these mutations. Most of them are in KIT. What is KIT or PDGFR? So these are the two most commonly mutated genes in gastrointestinal stromal tumor, but they're normal proteins. We all have these proteins in our body, and they're important for helping to regulate cell survival and cell growth. Normally, though, this is a very highly controlled process where certain things that we don't even think about will control the activity of these proteins, where if they're activated, then these downstream signaling pathways, so on this right diagram here, that's just a demonstration of KIT. PDGFR looks actually very similar. But when those proteins are activated, it leads to a whole bunch of other signals through these other proteins called RAF, MEK, and ERK, which is the MAP kinase signaling pathway, PI3K. AKT-mTOR pathway is another one where both of those are activated when the KIT protein is activated. And when those protein signals are activated, that then leads to cell growth, and it helps the cell survive. And again, usually that's a very highly controlled process. But what can happen in gastrointestinal stromal tumors is mutations can happen in the DNA that ultimately leads to changes in the protein. And having the presence of those mutations leads to abnormal signaling. So what was a very highly controlled process then becomes essentially just constant activation, which leads to abnormal cell growth and abnormal cell behavior, which then leads to cancers, and in these specific cases leads to gastrointestinal stromal tumors. So there are a number of different mutations that can come up. This is a diagram that was from an older paper. I actually took this from the LifeRaf Group website, that shows where are some of the more common mutations. And I'll show this a few times in different forms in the next few slides. But some of the more common ones are mutations in, so I'm not sure if you can see my mouse, but I'm going to point just in case, but exon 11 mutations are the most common places that will, or the most common place that will see mutations, where that's a mutation just inside the cell, where when that's present, that disrupts the normal KIT mutation function and leads to activation of it. But these mutations can happen in a number of different spots, and really everywhere that you see arrows are places that we know can be mutated in gastrointestinal stromal tumors, and they can be present in, and most commonly are present in, the protein called KIT, but we'll also see them relatively commonly in PDGFR, which is another protein that's very similar to KIT. But then some just don't have any mutations in any of these, and now with sequencing, we have a much better understanding of where those mutations are, or what's driving those so-called wild type tumors. So first, about 80% of patients with GIST will have a mutation in KIT, and that can be in any of those sites that we were just looking at. And I'll say this again, KIT expression by IHC does not mean that you have a KIT mutation. That's a very important point, and I'm repeating it because it's something that really is not a concept that everyone fully grasps immediately, but it's very important because knowing the mutation can help decide what treatment you need. About 10% of tumors will have a mutation in PDGFR, and the A is supposed to be alpha, which is the one that we typically will see mutations in. But for the other 10 or 15% or so of people, we won't see a mutation in KIT or PDGFR. And because of now the development of next generation sequencing, people have been able to sequence these tumors where originally we didn't see any KIT or PDGFR alpha mutations, and we've identified a number of different proteins that will sometimes be altered or mutated. Some of the none of these are common, but some of the more common ones, specifically in wild type GIST, are SDH alterations, which, as many of you know, is actually associated with a genetic syndrome that can predispose patients to GIST, and a couple of other things. We'll see BRAF mutations, which is a protein that is actually fairly commonly mutated in melanomas. And because of that, there have actually been drugs that have been developed specifically to treat BRAF mutant melanoma. But now we know that if we see those mutations in other tumor types, there can still be activity. And if you had a BRAF mutated GIST, that could potentially actually impact the treatments that you receive. NF1 is a gene or protein that is associated with neurofibromatosis, so another genetic syndrome that can predispose patients to a number of different types of tumors and growths. And gastrointestinal stromal tumors are one of the things that we see in that syndrome, and sometimes even sporadically it can be mutated in patients with GIST. And NTRK fusions are another sort of very specific type of genetic alteration, where what happens with fusions is actually different pieces of the chromosomes as cells are growing will break apart but then come back together. And sometimes two genes that are not typically next to each other will then get put next to each other, and that can create fusion genes. And that actually happens in a number of different cancer types. An NTRK fusion specifically can happen in many different cancers, but they have been reported in gastrointestinal stromal tumor. And because we have a good understanding of what actually drives tumors that harbor those fusions, drugs have been developed specifically to target NTRK fusion proteins and tumors that have them. And those drugs are actually incredibly effective. And I have a picture of that in a few slides. This is another way to look at that, where this is just a pie chart of the frequency of mutations that happen in gastrointestinal stromal tumors with a little bit more specificity, where they actually break down here the percentage of KIT mutations that are seen. So about 2/3 of patients will have mutations in KIT exon 11, which is just the most common mutation that we see. About 8% or so of patients will have a mutation in a different exon called exon 9, and that's actually relevant because it determines what dose of imatinib we need to use. But then about 10% of patients will have alterations in PDGFR. Another 10% would be in that sort of wild type category, or SDH deficient, which is generally actually assessed by IHC. We can confirm it sometimes with mutation testing, but really IHC is how that's when we say deficient, what that essentially means is when the pathologist stained that tumor for SDH using that IHC brown stain, it does not stain brown, where most SDH competent cells or tumors would actually have that in it. And then there's lots of other proteins that can be mutated, or genes that can be mutated, and they're all relatively rare, or actually very rare. But if you were to have that, we would want to know it because it could potentially impact the treatment. So really the general recommendation for mutation testing is every patient who gets started on a GIST therapy, which usually would be imatinib, should have mutation testing performed. Typically, we would start with testing KIT and PDGFR alpha. Different institutions have different practices, and none of them are right or wrong. But because the vast majority of patients will have a mutation in one of those two genes, that's a somewhat simpler way to do it. And though because of all of the advances in sequencing that have developed over time, we have a much easier ability to actually do a much broader panel of mutation testing, and also for much cheaper. So different institutions, again, will have different pathways for how mutation testing is done, where because this has been known knowledge, the mutations in GIST has been known for such a long time, really most of the sarcoma centers will have internal platforms or internal pathways to do mutation testing, where some, like my own institution, will do KIT and PDGFR testing first. And in the vast majority of cases, if there's a mutation in one of those two proteins, we'll know just by testing those two genes. And in about 9 out of 10 people, we actually will find a mutation just by testing KIT and PDGFR. And then essentially as a reflex, if there's no mutation detected in that more targeted sequencing of just those two genes, then we'll do the broader next generation sequencing to test a large array of proteins to see, well, we didn't see anything with the targeted testing. What if we do this other testing? Can we actually find anything by doing that? Some centers will do the broader testing upfront, and that's of course fine. Is it necessary? I think that's honestly debatable and a little bit controversial in the field. I think down the road over time, just as the cost of that sequencing continues to go down and as the procedures for it become more streamlined, I think that's probably the way things are moving. But at least right now, I would not consider doing a broad NGS panel upfront for the first mutation testing necessarily standard of care. But the testing that you do does impact the sensitivity of actually finding mutations. So there was a paper published actually very recently where they did more targeted mutation testing on a number of GIST tumors, and then they also really just explained other folks who have done the same thing, where in that initial testing, no mutations were identified in KIT or PDGFR. So those would have been considered wild type tumors, but then they did next generation sequencing, which is a much deeper sequencing, meaning that it gets better coverage of those particular genes, and mutations, even in those genes, were actually identified by using just the different method of sequencing. And this is just a big list of some of those mutations that were found that were actually missed on that first sequencing attempt. So that's why if your tumor does not have mutations in KIT or PDGFR, and that's the first testing that's done, then really everyone in that situation should have broader mutation testing done with next generation sequencing. There are many different ways to get mutation testing done. So one is, especially if you're getting seen at an academic sarcoma center, I think most of those centers will have internal platforms for doing next generation sequencing or for doing mutation testing. And you can speak with your provider about ordering it. There are a number of different commercial labs that will do it. Again, really most providers should have the ability to order these tests. These are just a few examples of companies that do it, but there are actually many out there. Some of the more common ones that you might have heard of are companies called Tempus, Caris, and Foundation Medicine, where they primarily do tumor testing or mutation testing from the tumor itself. Guardant is another company that actually looks at circulating tumor DNA, so that's actually a blood test. And there are many other companies that will do similar sorts of sequencing. And in order to get this done, just speak with your oncologist or speak with your provider, and they can talk to you about different ways to do it. Essentially, I view these companies' sort of end products and the testing as similar, where as long as the sequencing is getting done, in my own practice, I don't have a strong preference for who's doing it. What's important is that the testing actually be done. And just as a plug for the LifeRaft group, they actually have a collaboration with one of the companies called Tempus, along with another drug company called Bayer, where they're trying to streamline getting next generation sequencing done for patients who have never had sequencing, or for patients whose original tumors were in that so-called wild type category where no mutations were identified. And I put the website up here, but if you go to the LifeRaft group website, you can find this form. And if testing has not been done or it's not planned to be done on your tumor, then that's one way to advocate for yourself and make sure that the testing does get done. That being said, especially in some of the higher volume sarcoma centers, we do routinely check these mutations. And if we have an internal process in place, then especially the pathology labs where the testing is done routinely, might be a little bit hesitant to send tissue out to do the same exact test that they can do internally. So at least be aware that this form specifically might not be able to be done at all centers, but if the testing is not being done, this is really an excellent way to advocate for yourself and make sure that the mutation testing does get done. So now, there are lots of ways to get this mutation testing done. It gives us lots of information. What are some other factors that go into this? So the mutations in GIST really are not all equal. And there's actually we're learning now a pattern to certain mutations being present in GISTs in specific locations anatomically. And this is work that was done by Jason Siklik at UCSD and published very recently, where his group looked at tumors in different locations in the stomach, and they looked to see, are the mutation patterns different or the same in those tumors at different locations. And what they actually found was very interesting, in that for tumors sort of in the top of the stomach, the part called the fundus, those were almost always KIT mutant, where virtually every single one of those tumors that they tested had a mutation in the KIT gene. But then as you go down the stomach, that pattern changes, where by the time you get to tumors that arise in the bottom of the stomach or the antrum, they were actually more likely to have PDGFR mutations. And even many other different types of mutations like SDH deficiency or mutations. So the tumors that arise from the bottom of the stomach are much more diverse than the tumors in the top of the stomach, which is interesting. We don't know why that's the case, but it could actually help potentially guide treatment, especially in areas where mutation testing is not available. So for example, resource poor or resource limited countries or locations where they just don't have the ability to do sequencing. We can actually get a sense for what mutation is a tumor likely to harbor just by the location of it. And then I don't have a slide for this, but also exon 11 versus exon 9 mutations, there's a slight difference where I would expect to see an exon 9 mutation probably more likely in a small intestine tumor versus a stomach tumor. All of this information is nice to have because it can actually impact the treatment. that we would recommend. So even in the very beginning, the mutation that you have might impact what we do. This, or at least the data that led to the use of imatinib, is what I'm showing here, where this is actually a study that was done in patients with metastatic GIST, where patients were treated either with chemotherapy or with imatinib at 2 different dosing levels. And what you can see with the green line are events, so unfortunate events, patients essentially passing away from their tumors because doxorubicin really, or chemotherapy, really is just not an effective treatment. But with imatinib, people do dramatically better. And I showed a different chart from a different study earlier. This is for patients with metastatic disease. So, anyone who can get treatment, we really want to start it. And now that we have a better understanding, we want to use a drug that was designed specifically to block the KIT protein. So what you're seeing here is, especially in this bottom right panel or on the right side, so that red area is imatinib. So that's what imatinib looks like in its chemical structure. And it's sitting in a specific spot in the KIT protein, which then prevents that protein from having that abnormal signaling, which prevents it from leading to that abnormal cancer cell growth. And by treating just tumors with imatinib, we can actually halt the tumor growth, and in actually many cases reduce the tumor size, and in some cases even make them go away. So this is the science that led to imatinib. But then when mutations come, then that can lead to sort of disruptions in this diagram that you're seeing here, where the imatinib will either not sit well in the protein, or other changes can come up, which then lead to additional signaling that allows the protein to then circumvent this blockage that imatinib causes in KIT. And even for upfront therapy, the specific mutation that you have is actually relevant. And just a good example of that is for patients who have an exon 11 mutation, the dose of imatinib that we'll use, at least up front, is generally 400 milligrams, which is just the standard dosing of imatinib. But for patients who have an exon 9 mutation, we know that those particular mutations tend to be a little bit more resistant to imatinib, so we have to use a higher dose. So for patients with exon 9 mutations, they'll generally start with 800 milligrams of imatinib versus 400. But then, as you saw, not all patients have mutations in KIT, and there are some other mutations for which we now actually have very effective drugs. And this was a press release that was put out in January of 2020, where the FDA actually approved a drug called avapritinib for patients who specifically have mutations in exon 18 of PDGFR. And that's specifically because we know that patients with this particular mutation, this D842V mutation, will not respond to imatinib. And this drug was developed to overcome that. And it's actually very effective in patients who have this mutation, where this is what we call a waterfall plot, where each of these blue lines represents a patient, and it's showing the tumor size after treatment, where this 0 level is where the tumor started in its size. And then every single one of these lines that's going down is someone whose tumor reduced in size when treated with avapritinib. And remember, this is a mutation that just wouldn't normally respond to imatinib. So, say 5 years ago, before this drug was developed, presumably all of these patients would have been treated with imatinib, but then most of them actually would have had their tumors grow. Yet now with the introduction of this newer drug, it's actually very effective, and this is now what we would standardly try and treat patients with metastatic or unresectable tumors that harbor this mutation. And it's really dramatically changed the course of, how do we manage patients with this specific mutation? So if you have this mutation, we want to know it, because it would actually change the drug that we would treat you with. that small subset of patients who don't have KIT or PDGFR mutations, we now have a better understanding of what those mutated genes are. So this was work that was published probably about 5 or 6 years ago, where a lot of these mutated or wild type, not mutated GISTs will be either SDH deficient, so they'll have mutations in a gene called SDH, where there's actually a few different SDH genes, 4 of them. Any of them can be mutated and ultimately lead to gastrointestinal stromal tumors. But then there's a smattering of a bunch of other mutations, so NF1, BRAF, various fusions that we wouldn't necessarily expect to see or wouldn't be able to pick up on just the regular DNA sequencing. And because of the presence of all of these things, anyone with a wild type tumor should have a much broader sequencing panel done. And this is one example of that. So I mentioned NTRK fusions a bit ago, and this is just an example of a patient with a gastrointestinal stromal tumor that had an NTRK fusion and was treated with an NTRK inhibitor. So there's actually a few NTRK inhibitors that are approved now. On the left is a picture, actually a PET scan showing that very active. So these bright yellow areas are all active tumor. And after treatment, this picture on the right shows that all of those bright areas have essentially gone away, where there's still a little bit of residual tumor that you can see. So this dark thing in the liver that this top left arrow is pointing at is the remnant of one of those tumors, but it's not bright. It doesn't have that rim of sort of yellow, almost like a light bulb around it, and that's because it's responding really dramatically to this drug. And without sequencing, especially a very broad panel of sequencing, we would never be able to identify this particular fusion. So again, if your tumor does not have an identifiable KIT or PDGFR mutation in the first round of sequencing, you really want to get a much broader mutation testing panel done. Another biomarker that I want to at least mention in this talk, is just because there's so much interest in immunotherapy now, are there biomarkers to try and identify who would actually respond to immunotherapies, where immunotherapies are drugs that are targeted towards your immune system to try and actually stimulate the immune system to fight against the cancer. And they've been really revolutionary in a number of different cancers like melanoma, lung cancer, bladder cancer, certain types of colon cancer, but they have not been so successful with sarcomas, including gastrointestinal stromal tumors. But there are some patients who really do seem to benefit. It's a minority of patients, so probably somewhere around 10% or so of people will actually have tumor shrinkage with immunotherapies with GIST. We don't really have a good biomarker to try and truly predict who's going to respond to these types of therapies or not. We have some that are imperfect, so things like looking at the mutation burden, which is literally how many mutations are there in the DNA in the cancer, where if there's a higher number, we think that's more likely to lead to a good response to immunotherapy. But we've certainly seen patients who have very low mutation burdens who still have really great responses. And then PDL1 is another marker that many of you have probably seen, where that's a protein that is commonly expressed on tumor cells and also various immune cells. And that's actually the target of a number of these different immunotherapy drugs. So if it's highly expressed on a tumor, then we think that that suggests that someone might be more likely to have a good response with the immunotherapies. But again, just like with tumor mutation burden, we've certainly seen patients have really great responses, even though they don't have that PDL1 expression on their tumor. So neither of these are really perfect biomarkers, but at least at this point, they're kind of the best that we have. So we'll oftentimes check those things, and many of those, especially commercial panels that can be done with next generation sequencing, will also give an assessment of tumor mutation burden, and then as a separate test, many of them will actually check for PDL1 as well, specifically because we're just trying to see is immunotherapy potentially an option where we wouldn't use these up front, but for someone who's already had their tumor become resistant to a number of the other gastrointestinal stromal tumor drugs, so the different TKIs, immunotherapies are something that we'll at least think about. And then, as resistance develops outside of mutation testing, there's pretty much a standardized sequencing of TKIs that we use now, where the first drug is imatinib. For patients who have that D842V mutation in PDGFR, the first drug is actually avapritinib as of a couple of years ago. But based on a number of randomized controlled trials, the general sequencing that we recommend is start with imatinib and then use sunitinib and then use regorafenib, and then fairly recently ripretinib was approved, and then any TKI or clinical trial that we can get approved. That's all based on randomized controlled data. And you might think, well, should we actually repeat mutation testing once the resistance develops? And the actual answer to that is not entirely clear, even though we know that resistance is often driven by secondary mutations or additional mutations that the tumors can pick up and develop. And we actually have a pretty good understanding of what many of those mutations are. So this is a figure that I like because it shows actually some of the more common mutations. So the driver mutations or the primary mutations are usually in exon 9 or 11. They can be in other places. But at least for the KIT mutant GISTs, they generally would be in exon 9 or exon 11. And then patients are started on imatinib. They'll hopefully tolerate it, although not everyone does, and then also hopefully have a good response. But then eventually, after some amount of time, the tumors can develop secondary resistance mutations. And those can be in a few different areas in the gene. So one of those places is called the ATP binding pocket, which is a specific part of the protein that is encoded in the gene in exons 13 and 14, or in the activation loop, which is just a different part of that KIT protein, which is encoded by exons 17 and 18. And from large sequencing panels that have been done, we know that mutations in either any of those exons can actually lead to imatinib resistance. And what this diagram on the right shows is actually what mutation would be expected to be sensitive to what particular TKI. So these abbreviations are imatinib, sunitinib, regorafenib, avapritinib, and ripretinib. And the blue dots are indicating that a tumor that's harboring one of these mutations, so just in the top line, that's an exon 13 mutation, would be expected to be resistant to imatinib, but sensitive to sunitinib, and resistant to regorafenib and avapritinib, but sensitive to ripretinib. And I'm not going to go through each of these lines, but with this diagram, you can actually get a sense and in a certain way predict what drug might be best to use in someone who's developed resistance. But it's not perfect because especially with patients who have multiple different tumors, there's a lot of heterogeneity. So one tumor might harbor one mutation versus another one in the same person might actually have a different secondary mutation. So we don't always actually guide treatment based on this secondary mutation testing.
I just want to step in.
Mhm.
We do have 1 minute left in the hour, but I'm okay spilling over a few minutes to answer questions if you have the time, Dr. Wagner.
Okay, yeah, I'll try and breeze through this. So, in terms of how do you repeat tumor testing, so one way is to just do a tumor biopsy. That's limited in that you're limited just to that one specific tumor. And then the other way is ctDNA. So that's a newer technology, which is actually a blood draw, where we actually get a good spectrum of what is, or at least potentially, what's the mutation pattern that's more representative of the entire tumor, taking into account all of the tumors that are in a patient. And new data was recently presented just a couple months ago, looking at what's the actual detection limit. So I'll skip that slide. But how well can we detect ctDNA in patients, or circulating DNA? And really the bottom line from that was, in a large group of patients on a well-controlled clinical trial who had ctDNA tested for, about 86% of them had detectable tumor DNA just in their circulating blood. And from that, they were able to identify lots of different mutations, where this is a chart of how many mutations were identified in those patients, where about a third had one mutation, another third had two mutations, so potentially just one resistance mutation. But the other third had many different mutations. Some of them had 3, 4, all the way up to 14 different mutations identified. And I think that just highlights the heterogeneity that we see, and it also highlights why we don't always tailor the TKI to specific mutation testing if that mutation testing is done just on a tumor biopsy, because we're limited just to that tumor that was biopsied. This is just a demonstration of what specific mutations were identified in those patients. And really the highlight from that was that there's a lot of heterogeneity in the mutations that we see in patients who have developed resistance to TKIs. Without a very clear demonstration of resistance, we still use that sequencing of imatinib to sunitinib to regorafenib, et cetera. But I think in the future that might change. So ctDNA has the promise of identifying secondary mutations that hopefully more broadly characterizes the actual complete tumor burden in a patient. And thinking long-term into the future, this is something that we might use for longitudinal monitoring, so even potentially for surveillance, although right now we're not quite there yet with the sensitivity of the testing. We could potentially use it to assess response. So if these ctDNA levels go down when you start a drug, that might actually give us an indication for whether or not a drug is working. And just in terms of ordering it, I'm sure many of you would be interested in having ctDNA tested. Right now, I would not consider it standard of care, meaning that insurance companies, I would say, are probably unlikely actually to cover it. If they do, then great. But that would be a potential challenge for ordering this testing, because it's not cheap and you don't want to get hit with a very large bill. So just to conclude from all of this talk, so again, I'll say again, all patients starting on systemic therapy should have mutation testing performed. KIT expression by IHC is not mutation testing. Mutation testing has to be separately ordered. Basically, everyone should have KIT and PDGFR mutation testing done. For patients who don't have mutations in either of those identified the first time around, should have a much broader NGS panel done. And that's especially true for patients with wild type GISTs. So sorry I went a little bit over, but happy to take any questions.
Not a problem. It was an important topic, I think, to go over on. I think you definitely covered in the broad spectrum of areas about the importance of this testing. And I have to say, I was pleasantly surprised to see you highlight some of the collaborative work that we've done with investigators, like some of the missed KIT mutations paper that we published on, and also a big thank you and gratitude for pointing out our tissue testing initiative. Thank you for doing that. So because we're short on time, we will just follow up with 3 questions from participants. So the first question is, can you have 2 genes, one KIT and the other ZFHX3?
So I guess to broadly answer that, the first part, can you have 2 genes? The answer is definitely yes. Where even though KIT mutations are generally felt to be the driver mutations, what we see in cancers in general is that as these things grow in an abnormal way, they can accumulate additional mutations in any number of proteins. So I am honestly not so familiar with what that second one that you mentioned is, but many different genes or proteins can be mutated. Whether or not they're biologically relevant or actually impacting the tumor growth will really just depend on what the second mutation is. Sometimes we'll find things that look different or look mutant, but that's because when we're calling mutations, there has to be a comparison to a so-called normal DNA. And obviously we're all different people. We have different DNA sequences, and some variation just because we're all individual people is expected. So there might actually be some alterations that you'll see in those reports that are actually not relevant at all, and they're just because whatever reference genome they're using to compare and identify mutations doesn't have that alteration. So sometimes finding second mutations actually doesn't impact anything. It might not even mean anything for the biology, but sometimes it does. And just as an example, so it's possible to have a mutation in KIT and maybe another protein called BRAF, which I mentioned before, or RAS, where those actually do impact the tumor biology. And having multiple mutations in those specific pathways might make a tumor either more resistant to treatment or potentially just behave more aggressively.
Okay, thank you. Great answer. Can you explain TP53 exon 5 along with exon 11 KIT?
Yeah, so
I've actually been on 400 milligrams of Gleevec for 5 years successfully.
Oh, wonderful. Hopefully that will continue. And that's actually very similar to that first question, where tumors can have multiple genes mutated, where TP53 is actually the most commonly mutated gene in all of cancers. So about, I think, half or so of cancers in general will have TP53 mutated. It's a protein that's important in regulating cell growth. And when we lose it, so all those mutations, well, not all, but most of those mutations lead to loss of function of TP53. And when it's lost, that just sort of gives that cell a chance to become more aggressive. So that is actually a mutation that is contributing to tumor growth, but just by virtue of the responsiveness or benefit, it seems like, from being on imatinib for so long, KIT probably actually is the main driver there, but having both of those, I'm sure, contributed to the development of that tumor.
Okay. How long should someone wait until treatment fails to either test the tissue or assess progression?
So that's a good question. And I guess the real answer is there isn't a well-defined answer. And I think depending on who you ask, even in the sarcoma community, you'll probably get drastically different answers. And some of them will be very impassioned on, in both ways, where some people will say don't test at all because with the resistance, it doesn't necessarily guide treatment. That being said, I think the movement is more towards being in favor of checking for resistance mutations. And then when to do that, it really isn't honestly clear. I think if you go through that sequencing and certain things that you would expect, like if, say, you use sunitinib and the tumors are just resistant, would it be interesting to know what the mutations are that might be driving that? It certainly would be. I think still the third treatment that I would use is regorafenib, but maybe in parallel, try and do a mutation testing panel. I think where the one exception to that, though, where I think more people would sort of universally agree on is, especially if there are multiple tumors and really just one of them is behaving poorly, then it might be actually nice to know what's happening in that specific tumor, especially if it can't be removed by surgery, because we might try and tailor treatment towards the tumor that's behaving poorly and doing things we don't want it to do. I think that answer might change if ctDNA becomes more commonplace, because with ctDNA, in theory, we're actually testing the entire tumor burden. So of course, we're limited in that in order to actually detect a mutation, that tumor has to be shedding DNA into the blood, which I think is the big limitation right now for widespread use of ctDNA. It's that the sensitivity of it just isn't quite perfect. But that technology is going to improve
Right.
unquestionably over time. And I think looking into the future, I think that will become much more mainstream.
I said 3 questions. You have time for a couple more, or?
Yeah, that's okay.
Okay.
Uh-huh.
When we speak of becoming imatinib resistant, is this determined by a present tumor still growing? For those with no tumor currently present, then is resistance not relevant?
So that's a good question. And when I say resistance, I generally mean a present tumor still growing or growing in spite of treatment. Resistance could develop in someone who doesn't have any tumor that you can see, but really we would define that by having no tumor, then having tumor that's visible in spite of treatment. So we really don't know, and for a good reason, if there's potential for resistance developing for someone who doesn't have tumor that you can see, so someone who's getting treated with adjuvant imatinib. But is it in theory possible? It is, but generally when there's no tumor there, it's at least much less likely for resistance to develop, at least while you're getting treated.
I think that actually might help answer the next one. This person has an exon 18 PDGFRA for 6 years. Should they have a second test? And I'm assuming the next question a provider would ask, like, do you have like another
Right, yeah.
tumor that's growing, like to even consider testing? You would confirm that, right? Like, if you
Right,
have
yeah, I think it would really depend on the specific situation where, and then even for exon 18 PDGFR mutant GIST, although avapritinib is approved, some exon 18 mutations in PDGFR might actually be sensitive to imatinib. It's especially the D842V1 that's resistant. And I think really whether or not additional testing would be indicated would really depend on what exactly is happening. So if in spite of imatinib or avapritinib, there's still tumor growth, then I probably would be in favor of doing secondary mutation testing with a much broader panel.
Okay, amazing. Well, I wanted to make sure we fit some time in for questions. I'm glad that we got to do that. Thank you, Dr. Wagner, for the presentation today, for just taking the time to collaborate with us on such an important topic. We really appreciate your time today and everybody else who joined us. And so with that, I'm going to have us conclude and wish everybody a lovely weekend. Take care.
Thank you.